The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Tonight we're taking a look behind the scenes of your local hospital and how they deal with moral and ethical dilemmas. Stay tuned. You're watching Health Connections. Thanks for joining us tonight. My name is John Wiedenheft, and tonight we have Dr. John Schulz, who is the chair of the Albert Lea Medical Center's Ethics Committee, and we also have Paul Goodnature from the committee as well. And tonight we're going to be talking about medical ethics. And so first, John, why don't we talk a little bit about what the Ethics Committee does in Albert Lea, just so we can get a quick picture of what we're going to be talking about tonight.
Well, the Ethics Committee right now has several roles. We have a committee that we want represented. We want to make sure that we have all the right players on it to address ethical concerns, and also to find out whether there might be concerns that do not have ethical implications but have other implications like legal or maybe compliance concerns. So we like to separate those out. So our committee members are very critical to the function of our committee. We also have a rapid response team, a consultation committee, so that any nurses, patients, physicians that would like to talk about an ethical concern they have, they can get back to us, and we can address it very quickly.
So if I was a nurse or some other type of physician, that I would be able to contact someone on this rapid response team. Can you give me an example of something that might happen, where a situation where something like that where a nurse might want to do something like that?
Well, we have had concerns that we have addressed in the past where there was a DNR, DNI directive. For instance,
what is that for?
This is a do not resuscitate directive that the patient has put out, or do not intubate, which means put a tube down into the trachea. And this patient was scheduled for surgery. And there are obvious problems there from an anesthetic perspective, because we are taking the patient down the road. We are giving them medications that might drop their pulse rate, might drop their blood pressure, and require certain parts of the resuscitative process, and certainly require that intubation of the trachea. So we've had calls on that we needed to respond to very quickly.
It's very interesting. Now, Paul, you're not a physician at the medical center, but so tell me how you got involved on the committee.
Actually, it was about 5 or 6 years ago, and I was teaching an ethics class for Riverland Community College, and a surgeon called me and said, "Would you like someone to come in and talk about medical ethics?" I said, "Absolutely." And as a result of that continual work, I was asked to be a member.
Great.
It's been a great opportunity for me.
Now, ethics has always been a big part of practicing medicine. It's always been part of the code that physicians operate by on a daily basis. Where has ethics come from in the last 2,000 years? And we don't need to talk about the last 2,000 years, but where have ethics come from, and where are they today? What do you deal with from the history and to today?
Well, I would say that ethics is actually a branch of philosophy. And the one question that ethics asks, the ultimate question, is what is the good life? And the corollary is then what is the best way to live? And so in an ethics class, we will often start with Plato, Socrates, Aristotle, right on down the line. But in terms of what's happened in medical technology within the last 4 decades or so, that has really created a need for medical ethicists in our time that didn't exist as such before.
Now, what would be some of those examples? Maybe, what was the impetus 40 years ago, 50 years ago?
Dialysis machines, when they were first created, there was a very limited supply. And the ethical question came about, who gets to use them? How do we prioritize? And so there were all kinds of formulas set up, is this person young, old, educated, intelligent, whatever. And people realized, well, this isn't very ethical either, and it became a luck of the draw thing, basically.
Sure.
To get access to the machines. But that was one of the first real dilemmas that was created by technology.
And so really at that point in time, it was the use of a new technology and the limited use.
Just because there were so few.
Yeah, exactly. What corollaries or what other examples are there in today's medicine? What technology is there today that is really causing some of these same issues?
Mayo Rochester, with their ethics committee, has a subcommittee just focused on transplants and the decisions and the difficult ethical problems that kind of revolve around who gets a transplant, when, where, and they've even put written policy that has to do with how they will handle people coming from other countries where you may be able to procure an organ, which is certainly not accepted in Mayo's Rochester's
and that's kind of been a large issue. I think a few months ago even that there were some issues, I think, out on the East Coast with some transplant, paying for transplants and things like that.
People putting them on eBay, say I will donate an organ for so much money. Well, that was stopped immediately, but some people actually tried to make money that way.
Are there any regulations on hospitals or other care centers to have an ethics committee? Where does the hospital say we want to have or we need to have this ethics committee?
I think it's more filled a void.
Okay.
And again, one of the problems we have with any particular issue that comes out is deciding whether maybe it's a legal issue, maybe it's not really an ethical issue, or whether it's compliance, whether we're living up to the Joint Commission's criteria for how we're supposed to handle a particular situation, or OSHA's. So we have to sort through that first. But
a little bit of history might be helpful here. I don't know if you remember the Karen Ann Quinlan case. This was back in 1973, and it was very similar to the Terry Schiavo case. And because there was no advance directive or do not resuscitate order, and the family, was in conflict about what to do in the situation, it went all the way to the New Jersey Supreme Court. And the New Jersey Supreme Court, this was back in '73, said we should not be dealing with this. This should be handled by ethics committees. And then in '83, there was a presidential commission that recommended that every hospital have an ethics committee or staff ethicist.
Okay.
And then I think it was in the '90s that there was some type of federal requirement that said there must be a staff ethicist or committee. But one thing I think is very important to remember about the committee is that we can only make recommendations. The ultimate decision is up to families and the individual patient.
So,
but they will come to us for some consultation.
So sometimes what family members will come and ask for a recommendation? Is that kind of what you were alluding to?
They're in a moral dilemma, an ethical dilemma, especially at the end of life. What do we do? Do we continue? And this is part of that technological aspect that creates...
How can families alleviate some of that? I know there's some other hospitals in this region in southern Wisconsin that are dealing with a lot of this, with advanced directives. What can families do to avoid some of these conflicts that they have?
I've told students time after time, I don't care how young you are, if you are a legal adult, get that advanced directive written out. And you can go to your local medical center, and they'll have copies there. You can fill in what you want and turn it in, and it's kept on file. And if something like that happens, you wouldn't believe the moral pain it relieves the family if they know for sure this is what the person wants.
Is there a legal obligation for hospitals or physicians to follow those living wills or advanced directives? I've heard sometimes stories of physicians not following it, or it's not written, or it's not there. There's not a copy present. What happens?
A physician has the right to follow his own instincts as well. If he feels uncomfortable going into an area, he is not required to do that.
Sure.
But he has to then explain his rationale for backing on and make sure that another provider is available to kind of pick up where he's having an ethical quandary.
Sure. Well, that's very interesting.
Just one other thing too, in terms of we're talking about oftentimes this end of life with technology, but also the beginnings of life. There was a very interesting case with frozen embryos now, in vitro fertilization, so on. There's a case on the news just this past week where one couple wanted to become pregnant. They had frozen embryos and they were given the wrong embryo.
Yes.
And talk about a dilemma for people, because now the family that is pregnant has agreed to give up the child as soon as it's born to the actual biological parents. But can you imagine if those two couples had not agreed? And they still said they have a lot of problems to work out in terms of will there be visitation, or connection with them, and that's just one of the things. The technology and then the mistake combined with the technology really creates an ethical dilemma.
There's an incredible amount of issues. You probably see a wide variety of a wide spectrum of all types of issues, whether it's something that from a family perspective or something from an institutional perspective. I think there's lots of things that happen. One of the things I think is what we're kind of leading into was informed consent. People knowing the full effects, benefits, and risks of procedures that they may go through. We were talking about getting ready for surgery and things like that. How does informed consent and making the patient and their families aware of these risks and benefits, how does that fall into medical ethics? Where does that fall?
Well, it's a basic ethical principle is the right to know, and I'll let you take it from there.
I think there's some legal ramifications there too. I think you are obligated by law to provide the risks, benefits, and alternatives to any procedure you perform, and that involves the informed consent of being honest. But how much you provide and what bias you introduce, that kind of gets into the ethical arena.
Well, and we actually have a caller who's calling in about a situation. So, caller, what is your question?
My question is, if you have a 90-year-old patient who has no insurance and a broken hip, and they still have a pretty decent quality of life, what about a hip replacement, and what are the ethics involved with paying for that, and without insurance, and the age of the patient? Thank you.
Thank you for the call. So we have someone who is a little bit elderly and they need a hip replacement, but they don't have that insurance. And without maybe getting into some of the more political discussions about insurance and coverage and things like that, what are some of the ethical dilemmas that physicians or even families, let's maybe talk about families first, how do they deal with some of these things if that's a pressing need for a family?
That's a difficult question. I think probably the first step would not be to go to the ethics committee, because it sounds like something that needs to be done relatively fast. Not that we can't do that,
right? But
I think the other routes seek, through social services, medical assistance, Medicaid, whatever. And you could speak about the
I think center. If there's a hip fracture, there's no issue.
It needs to be taken care of.
It needs to be taken care of, and it will be handled at what Dr. Schody or Dr. Ekstrom at Albert Lea Medical Center think is the right way to do it. And I don't think any of us on the medical staff look at the cost or the insurance or any of that. I think that's important for people to recognize. Now, for a total hip replacement, which is much more of an elective thing, you know, that's an issue that really gets into the cost of health care today.
Yeah.
That's a wonderful question.
It is.
And I'm not sure what the right answer is, but I can tell you that recently we have done several patients that fit into that. I mean, so it's not uncommon to do patients even in that age range that everything else is going for them to replace their hip.
What is, you mentioned that you've done, you've had several of these situations recently.
Recently, patients, and I'll just say over 85 that we have done total hip replacements on.
Okay.
And, you know, again, I think...
What was their financial situation? Some of them...
I don't have to know, and
Sure.
I kind of prefer
So
not to
you
know.
don't know.
Yeah, I don't know.
Yeah, so really, I mean, as a physician, you're really, you know, looking out for the patient, the best thing for the patient.
Right. And
What would
whether
be
they
the
paid-
procedure for this caller then with her parent to get the services she needs, the medical
Well, I
services
think,
she
you know,
needs?
part of it was addressed, you know, with some of those other services that you mentioned. You know, to me, it sounds, and you can agree or provide some other advice if you want, but to talk, is there someone at the hospital, local hospitals, there's always someone on staff who really helps with issues like this. What might that person's position be, or, you know, within the Mayo Health System or any other hospital in this area?
Well, with our ethics committee, we have on our brochure, just call the hospital, ask for the hospital administrator, and the administrator will refer you to the proper source. That would be one.
Okay.
Yeah, I would think that starting with the orthopedic surgeon and talking with them, and you know, I think they would at least be able to tell you whether there were any roadblocks. I'm not sure I was hearing from her that there were roadblocks there. But
I think one of the concerns that a previous member had, even in Albert Lea, said that there are way too many people here who do not come to get medical help in time because they don't have insurance, or they have such high deductibles that they're afraid that they won't be able to afford what's going to happen. There are other routes to go if you don't have the money.
Ask the question.
Ask the question, yes. Ask the question.
And don't be satisfied until you get the answer. Don't leave until you get the answer that you...
That's right.
So that's, I think those are some really important things for all our listeners to take home tonight. And maybe even talking about surgeries and things like that, one of the things I think we're all used to now as patients and as really signing the privacy papers that when we go to a hospital or a clinic or the emergency room, privacy has really become a big issue in the last couple of years, and technology, electronic health records are coming around to a lot of different hospitals, especially in this region, and nationwide that's going to be coming around soon. How are records, how is that privacy? Do ethics fall into how the hospital handles those records now that they're much more easily disseminated, that they're electronic? Because they're just files now, they're not paper.
I would say that that's more of a compliance concern.
Okay.
Because it's pretty well regulated how we have to handle those records. And we even have groups that go through the hospital looking at computer screens to make sure there's no patient data up and making sure that people follow through. So we really are trying to protect the privacy. Not really an ethical issue as much as making sure we comply with the
And I think that's another aspect of healthcare too. That if you take a look at the technology department within the hospital, I know someone who works in that area, you know, and we just had a situation with the ethics committee. You had gone to Mayo for some conferences on ethics, and they wanted every member to see the particular document. It was not a personal file or anything like that, but there were a few of us who couldn't access it because it was locked into the Mayo system.
Yeah.
So there are a lot of, you know, what should I say, protections out there, but they have to be maintained because we know what hackers can do too with the technology.
And the whole process of the HIPAA regulations is a double-edged sword. You know, people go someplace and they would like to have their health information transferred there, and they can't do it because they have to go through a release of information. These are the privacy regulations. Yeah, health information Portability Act. Yeah.
How does communication, whether it's among the committee members or among physicians or different departments, how does communication play into the role of ethics? Maybe Paul, you want to take that, because you know, your history of getting onto this committee was someone coming to you, and you know, there's that interaction of communication between a physician and yourself. What role does communication play?
Well, I think it's vitally important. As I said earlier, you know, we can only make recommendations. And the first case that came from the community when I was first on was a very interesting end-of-life situation. And it was a person who was a ward of the state, and so on. And the administrators at the nursing home said, we need some help. They came to the hospital and sat down with us. And I mean, there's quite a range of people on that committee. Mm-hmm. And it was a great relief. And I was telling Dr. Schulz before we were on the program here, it's one thing to talk about hypothetical cases in class, and then you get to an ethics committee meeting, and it's a living human being that you're dealing with.
Right.
And it hits, the weight of it is very heavy. And so one of the consolations of that was the fact we were able to communicate so well with the administrators, along with one of the siblings of this person, and come to a consensus even. And that relieves some of the pressure. Mm-hmm. But it took us a long time to get to a decision. Mm-hmm. And there were a lot of questions asked back and forth. And that's been one of the great things for me individually, is just learning a lot of the medical implications of these cases.
Now, you brought something up very interesting, I think, that when there was the person in front of you, that this is the situation, this person is what we're discussing, what we're talking about. How does that change the discussion? How does that change how you look at things? It's not a classroom setting anymore. It's someone, or it's their family members that are out in the waiting room. How does that situation change how you look at things?
I think it makes it easier.
Okay.
I really, in fact, I like all the family members to be there. I think communication is critical. And I think what we found is that so many ethics issues just disappear when we get the right people and we get the family members to all sit down with the patient and you talk with them and just open up the lines of communication. Yeah. That it really makes things a lot easier. And you realize that families haven't talked with each other about some of these issues that have now just...
and that's very important for families to do. You know, we were talking about that at the beginning of the show.
Right.
It's exactly that families need to talk about these things.
And it's very interesting that a lot of people will recommend that, for instance, if you're writing an advanced directive, to have someone outside the family be the one to implement that at the critical time. Because sometimes family members will say, yes, I really agree with you, but then there'll be that moment, well, I don't think I can let so-and-so go, you know, and it becomes more of a selfish interest as opposed to someone who would really want your wishes to be carried through. But I really think that the whole business of being able to sit down, it's one thing to get, even in our ethics committee, to get a real case study that's written up. And we have spent many hours in the meetings, you know, picking out details and saying we need to call this person, we need to talk to this person needs to come in. So we can really, you know, see the implications here. Yeah. Because that really makes a difference. Yeah. And I just tell you, that time when we had the people with us and we came to a consensus, it was not a comfortable thing ultimately, but it gave us, we didn't have that moral pain, they say, you know,
yes.
when it was over.
And we have a few minutes left, but we have another caller on the line who has a question for us. So, what is your question?
I'm a caregiver in a group home, and I was wondering, what ethical considerations do you use as criteria for a mentally handicapped adult female who has been raped and is now pregnant? She wants a baby, but she isn't capable of caring for herself or a child, and she has no living relatives, is in, like I said, a group home. Thanks. Bye.
Thank you very much, and in case you weren't able to hear it, the person who called was a caregiver, and dealing with a mentally handicapped individual who had been raped and is now pregnant. So she's not able to take care of, obviously, herself or the future child. What could happen in that situation? How can medical ethics help this, or what other services are there besides, obviously, the road of social services?
Well, I think it would be very important to deal with the social services people and then make contact with the local ethics committee in dealing with the situation. And another thing is that they need to know the specifics of the law concerning vulnerable adults and how they are treated within the community and the medical community.
Okay.
And that's number one, I think. But I certainly would think that a referral to the local ethics committee would be. I can't answer the question tonight,
Yeah. Not.
And this is one of those situations where, with an ethics committee, sitting down with these people who are the caretakers.
Exactly. That's kind of exactly the situation that the committee is meant for, to sit down and really discuss and over, whether it's a short period of time or a longer period of time, to really sit down and gather some of the facts and testimony. It's not a legal situation, so you don't have testimony, but people talking about these issues and getting them together. And I really want to thank both of you tonight for joining us. We just have a little bit of time left. Where do you think ethics committees are going to be headed in the future? Technology was the impetus for a lot of this. Where are we heading?
I think we'll be dealing with many of the same issues we have about interpretation of advanced directives and going over do not resuscitate orders and where they're applicable. But I think we'll be dealing with all sorts of new issues. Issues like distribution of limited resources, even including something like with the swine flu.
Yeah.
I mean, some real difficult decisions could be made
if
there's
going to be
limited
issues. Well, again, I really want to thank both of you for joining us tonight.
Thank you for having us.
Wonderful conversation, and thank you for joining us. Please join us again next week for another episode of Health Connections. Thanks, and have a good night.